Cardiovascular Dysfunction, Sandra Monk. Cardiovascular dysfunction, to begin talking about that, we need to look at, what we would do for a diagnostic evaluation. And one of the things we can do is simply to do an EKG, an electrocardiogram. And that can help us to Cardiovascular Dysfunction, Sandra Monk, Chapter 48. To begin with, we need to look at an identification of cardiovascular disorders in children, and those come in two groups. The first is congenital heart dysfunction, and these are clinical consequences of that will result in congestive heart failure or hypoxemia, low oxygen levels. And really any abnormality with a second heartbeat or sound is suspicious. And so if during an assessment you hear any additional sounds or prolonged sounds, then that certainly bears further investigation. Any symptoms such as poor weight gain, poor feeding habits, or fatigue during feeding also are suspicious, as are respiratory disorders that keep reoccurring, or if a child has exercise intolerance. There are two groups. There's congenital heart disease, which can result in congestive heart failure and hypoxemia, as can the acquired type 2 that comes from infections such as rheumatic fever. Whenever we do a history and physical, we do an inspection, we do palpation to see if we hear, feel any additional vibrations that wouldn't ordinarily be normal, and percussion to check for cardiomegaly. And in addition, we do auscultation, and as I've said before, you would definitely, any kind of extra heart sounds or any type of prolonged sounds would result in further investigation. And heart murmurs are pretty common in children. They can even outgrow them. A lot of times it's just the heart structure and additional vibration outside of those heart structures. And so children have what's called an innocent murmur, and it is a murmur that there's not actually anything wrong with the heart structure itself. It's just the vibration around parts of the heart structure. Diagnostic evaluation, we may do what is simply an X-ray to look at the heart. I didn't include that here in this list, but that's one of the first things that might be done, and that will show information on the heart, the size, the configuration. You can look at not only the heart, but any changes in pulmonary structure. In addition, that X-ray stands as a permanent record to look at the heart to see if it's enlarged or if there's any changes, and so that would be something the least invasive. We always go from the least invasive to the most invasive. In addition, they might do an EKG, an electrocardiogram, to evaluate for dysrhythmias and electrical conduction problems. One thing I didn't mention that could also be diagnostic would be to do vital signs. Believe it or not, a stethoscope is considered technology, but you could take vital signs, and we don't generally take a blood pressure on a child under the age of 3. Now, different hospitals and different pediatricians may have a different idea on that. If we suspect a cardiac problem, then they probably would in a child under 3, but normally healthy children we do not. And then you might check blood pressures in all 4 extremities on a child, for example. We would check their O2 sats with their vital signs, and that's pretty standard with all vital signs on pediatric units, that we check their O2 sats. We might do an echocardiogram, and an echocardiogram actually is a is a standard as far as non-invasive. It is the study of choice to diagnose cardiac dysfunction, because it can be performed at the bedside with 95% accuracy, and it is a Doppler type of examination with high resolution. And the limitations are generally just based on what it is the operator's level of training, and they're really better read by the pediatric cardiologist. You also can have a 3D echo, you can have an MRI or a CT to look at cardiac function and ventricular volume. So those are all good ones. Cardiac catheterization would be your higher, more invasive type of procedure. And we're going to talk at length about how we'll prepare a child and the family for the cardiac catheterization. Here's the catheter will eventually travel to the aorta, through the aorta to the heart. Very commonly with children we have groin insertion or wrist insertions, depends on how big the child is. If it's a pretty big child, then they may even actually have, go in a brachial area. And in these with the cardiac catheterization, they're looking at peripheral blood vessels. They go through a peripheral blood vessel and advance to the heart, and they can measure the pressure inside the heart in addition to oxygen levels in the heart chambers, and look at the heart structures and blood flow patterns. So it's pretty it's good for diagnostics. It's also good for interventions. Sometimes cardiac dysfunctions can be remedied through a cardiac catheterization and intervention. And we'll look at some of those. They'll actually correct some of the anomalies, like if there's a closed area in a vessel, it can be widened some with a balloon type of instrument. Cardiac catheterization, as far as nursing management, kids are probably going to be this is going to be done under fluoroscope, and they may give the kids a little something just to kind of help them to be still. Because the catheter is going to go in, and we might tell them that, that this is something that's going to go into the tip of their heart, and they're going to look at it and take a picture, and they're going to, look at a picture of their heart. So that might be one way you could talk to kids about it, because you don't want to be real specific unless it's an older child or an adolescent. Kids may benefit from a tour of the cath lab first. Or if they're school age or older. Younger than that, you probably can use a doll and try to explain some of this that way. And you do want to prepare the child, like we talked about with hospitalization. We want to make sure that the child, knows that they're going to have a procedure, but not too far ahead of time, maybe a week or so ahead of time with the older kids, so they have time to tour the cath lab. But a younger child, we probably would just a day or two ahead of time. If it's a baby and they have diaper rash, they will delay it if they're going to use groin access. Congenital heart disease can be a major cause of death within the first year of life, and that's secondary to disease processes following prematurity. The most common anomaly is ventricular septal defect, and we're going to look at all of the different types of heart anomalies in class. When you come to class, any teaching, okay, we already talked about that, teaching that you might do. And then sometimes this congenital heart disease will come with another anomaly. The trisomy 21, children with Down syndrome, they will check them very closely, to make sure that they do not have some type of cardiac anomaly that goes with the other genetic change. Circulatory changes at birth. We're going to do an activity in class on that too. You may recall some of this from your maternal child health class, the changes with the umbilical vein and the umbilical arteries and how that circulation changes after birth. The foramen ovale is an opening in the septum between the two atria, and it allows for blood to bypass the lungs that are filled with fluid, and this should close at birth. And then the patent ductus arteriosus artery connects the aorta and pulmonary artery to close, and it usually closes within minutes or just a few days of life. It can be minutes up to 12 to 24 hours normally. Sometimes they want to keep this open if they've got some other, say, mixed flow type of cardiac defect, to allow for some type of oxygenated, circulation. The ductus venosus carries highly oxygenated blood from the placenta, and it closes shortly after birth as pulmonary circulation is established. And next we will talk about these are pictures. The picture A is prenatal circulation and B is postnatal circulation, and we will look at those in an activity in class, just to kind of refresh your mind about where the different like the patent ductus arteriosus, where that might be located at, and we're going to look at some heart structures that have been affected by heart defects, and we'll draw those out, and so you'll have a better idea of what each of those are. We're going to talk about them just briefly in this PowerPoint presentation. You have, in congenital heart disease, the classification of defects. You have two different kinds. You have acyanotic and you have cyanotic. So acyanotic is like it sounds. The child would not be as symptomatic with symptoms of low oxygen levels and cyanosis, at least not in the beginning. It could be caused from an atrial septal defect, and the direction of the blood flow goes from the left to the right atrium, and so oxygenated blood returning from the lungs to the left atrium shunts to the left, where it mixes with deoxygenated blood, then returning from the body, causing an increase in volume, and that's really hard on the right ventricle. The O2 sats may be normal and not a lot of symptoms. With a large atrial septal defect, they'll have to have medical management for pulmonary congestion, and we're going to look at those specifically. Now, if they're cyanotic, that's a different kind, is if they have a cyanotic lesion, something like tetralogy of Fallot, where a lot of the vessels are transposed in ways that they shouldn't be. They have, actually that's 4 different anomalies, where they have a narrowed right ventricle outflow, they have a ventricular septal defect, an overriding aorta, and that causes them to have deoxygenated blood flow, and so this has to be corrected pretty soon. And they have a right to left shunt. It passes into the aorta but has not been to the lungs, and so that causes symptoms of varying degrees of cyanosis based on the severity of the disease process. This is a comparison of acyanotic and cyanotic. I would not ask you to specifically name these based on that, but I would expect you to understand the difference between cyanotic and acyanotic and what is going on there. So with acyanotic, could either be increased pulmonary blood flow or an obstruction to blood flow from the ventricles. Or you could be cyanotic with a decreased pulmonary blood flow or a mixed blood flow. So we're going to get a better idea of that in our class. Here are some defects with increased pulmonary blood flow, which would be acyanotic, the atrial septal defect, and then you see the ventricular septal defect. These are holes in the septum that separate the chambers. One is between the atria and the other one is between the septums. If they have a hole in the septum between the right and left atria or between the right and left ventricle, it creates problems later in life, and they may need surgery by about age 5 to 6. It really just depends on what size it is. Sometimes these are so large they can't even be repaired, so they would be more symptomatic. and they're classed by location. They can be like a pin size hole, or it can be a very large hole, and most of them close on their own, and it doesn't end up being a big problem. About 6 in 1,000 births end up having some type of cardiac anomaly, according to our book. So it's pretty common enough that we need to talk about it as nurses. Here's a ventricular septal defect. Is an abnormal opening in the wall between the two ventricles. And here are some defects with increased pulmonary blood flow. The patent ductus arteriosus, which is failure of that to close, of the normal fetal circulation to close, and so it causes a left to right shunt and increases the work of the left side of the heart. And here's an obstructive defect with a coarctation of the aorta. You can see it's in a very different place as it comes over. The trunctus comes over, and there's a narrowing of the coarctation of the aorta. And blood exiting the heart then meets an area, an anatomic narrowing or stenosis, and it causes an obstruction to the blood flow. So then the blood can't, go out, and then it backs up into the chambers and into circulation. Then there's pulmonic stenosis, and it's a narrowing of the pulmonary artery at the entrance, and it causes right ventricular hypertrophy, which is an enlarged right ventricle due to the resistance and a decreased pulmonary blood flow. And the resulting consequences of that would be congestive heart failure. They may have a pretty significant heart murmur, and this can sometimes be treated, as you can see, with balloon angioplasty that I talked about, that can be done in intervention as an interventional correction to that. Defects with decreased pulmonary blood flow will result in cyanoses, and one of those we said was the tetralogy of Fallot with the 4 different anomalies. The kid is going to be cyanotic usually at birth or shortly thereafter, and they may have TET spells, and we're going to talk about TET spells. And it can be, if it's so severe, that this child would need, a heart defect, they just try to, get them to, or need to get a heart transplant, in order to be able to live. They try to get them to that point. Sometimes they're strong enough, and sometimes they're not. Or sometimes they're able to do a complete repair, or sometimes they have to do the repairs in 3 or 4 different surgeries. And, the child is weakened, and so sometimes that has very good outcomes, and other times it can have a high mortality rate. Here's a tricuspid atresia, a hole in the septum between the right and left ventricles with cyanosis, with a tricuspid atresia. And then we have what is called mixed defects, which is could be transposition of the great arteries or vessels, where the blood is actually mixing. Some of the oxygenated actually mixes with the oxygenated, and so they don't have as good a capacity with oxygenation. Hypoplastic left heart syndrome can be an underdeveloped left side of the heart. In fact, it can be so underdeveloped that it just is can be non-existent. There's just the right ventricle. Of course, that doesn't work too well for circulation. Congestive heart failure, the inability of the heart to pump an adequate amount of blood into the systemic circulation. I would expect you to know that definition. And it can result in tachycardia, pulmonary congestion, cyanosis, dyspnea, systemic congestion, which can result in hepatomegaly. So that might be one thing that the pediatrician would find upon an assessment, that this child has an enlarged spleen when they're doing percussion, or an enlarged liver. They may have distended neck veins, just like an adult would, and cyanosis and nasal flaring, which is real real telling on a pediatric patient if they have nasal flaring. It means they've got some type of oxygenation problem. It can be right or left side failure with congestive heart failure, and the heart muscle may become damaged if left untreated. And this is from the congestion backing up. Now, a child can have congestive heart failure from other reasons as well. In children, it's mostly due to congenital heart disease as the reason they'll have congestive heart failure, rather than heart damage like an adult would have from an acute coronary syndrome. With diagnosis, they have various clinical symptoms, which would be some of the things we talked about just in the last slide: the tachycardia, distended neck veins, dyspnea, and those sorts of things. And they also may have, as a baby, they may have feeding problems. And so this is always, always something that we're suspicious about. If a children will eat, they will nurse, they will, take their formula. So if for some reason that they do not, eat well, then, that's one of the things that's checked out. That's one of the differential diagnoses, is they'll look and see if the child has some type of cardiac problem. And kids that do have cardiac problems, even if the parents are feeding them, they just don't grow and gain weight the way that a child that doesn't have a cardiac problem would. And so parents need to know that. They need to be fed on demand. They need to be fed every 2 hours. The parents may need to wake up during the night and may have this child on switch off, like one parent or the other parent or a grandparent, and so that this child's being fed every 2 hours, because they just get too exhausted to eat enough sometimes. And then in addition, this is a big stress on their bodies. And so the therapeutic management, the goals of treatment would be to improve the cardiac function, and that's the same as you might do with adult cardiac patients. They're going to have oxygen, they're going to have digoxin, they're going to have vasopressors, they're going to have medications to cause their the heart to pump more efficiently. They're going to we have to remove the fluid and sodium, improve tissue oxygenation, and most importantly, as important as any of those other things, is to maintain that nutritional status like we just talked about. And we want to make sure that this kid has enough food high in potassium, so like bananas, oranges, and leafy green vegetables, or some type of food along those lines. Okay, now when they're administering drug, this is another big concept when you're talking about pediatric patients. The parents need to know about digoxin. It's got to be given very carefully in a correct dosage, and they really need to have a measuring dropper to measure that in, or a measuring syringe. Teaspoons vary, and so parents really need to know this is one that you've got to really be careful with. If it's an infant, the medication can be dropped into the side of their mouth or towards the back of their mouth. Some of you've done that in clinical. Really, you should not mix medicine with other food or fluids. And if a dose is mixed, don't mix it with milk. And if they miss a dose, then the parents should be told not to try and make it up on the second dose, because that can result in toxicity, because of the very narrow therapeutic dose that is for children. So, if they should get digitoxic, it's going to look like nausea, vomiting, and anorexia. Now, these kids are already not eating very well, so the vomiting would be, vomiting that just doesn't, kind of resolve. And so if that starts, then the parents really need to check that out. It could be something else, but it very likely could be that they are digitoxic. Other type of things you might see, they might have some dysrhythmias like bradycardia. So their heart rate might be very low or slowed down. So we want to increase cardiac function, remove fluid, increase tissue oxygenation, decrease oxygen consumption, decrease respiratory distress. And we really want to support these families. It's going to be very frightening for a family taking care of a child that has a chronic illness like this. So we want to support the family and the child psychosocially. And kids really don't need to be isolated. That they may get tired easily, but when they get tired, they'll stop playing. And so sometimes parents will keep them from playing with their brothers and sisters, or keep them from playing with other kids, trying to really shelter them. And it's just not good for them psychosocially to grow up that way. And particularly if they're not in preschool, they need to somehow be socialized, even if it's just attending preschool part of the day. Okay, hypoxemia is identified by decreased arterial O2 sats. Hypoxia, which would be the low oxygen saturation, that would be measured, and then cyanosis, which is a more observable that with the blueness in the typical areas and the nail beds around the circumoral around the mouth, and it results from desaturated blue blood in the systemic circulation without it passing to the lungs in the case of cyanotic or mixed blood flow cardiac anomalies. Another thing about hypoxemia, some of the other clinical manifestations are polycythemia, or clubbing of the fingers, hypercyanotic spells, sometimes called blue spells or tet spells, and these can happen real quickly. Kids that have these, they typically have a loud murmur from birth to age 1, and they'll have difficulty with feeds and failure to gain weight, and they may have not be meeting those developmental milestones that we talked about. They have a lot of dyspnea on exertion, and they may have clubbing of their fingers and of their toes. Now, if a child gets very cyanotic, it very likely could be a tet spell, particularly if they've had a history of this. And all you simply do is to move to a knee chest position. Bring their feet up to a knee up to their chest, and that way the lower extremities don't have to be perfused, and it helps to conserve the oxygen for major organs, and until we can get the kid through the tet spell. They're going to have a very low O2 sat. And you want to promptly treat this. If it's a child that is in the hospital, they may use prostaglandins. This is like on newborns. They'll use prostaglandins to keep that ductus arteriosus patent until they can repair whatever it is that's causing this. And you need to promptly recognize the spells. It can happen during blood draws and IV exertion, just from the pain and from the stress of that. And so kids that are bad cardiac, we need to be watching them for that. And 100% O2 while the kids are if they're having a tet spell with the knee chest position, 100% O2. We'll get the oxygen on them right away, and they probably are going to have an IV. But if they did not, if they were coming in this way, that would be, we're going to do airway, we're going to do IV, so that we can treat what's going on, get medications on board. And we want to make sure that they are hydrated to prevent dehydration, which could lead to a risk of cerebral hypoxemia and a stroke and subsequent brain damage. Therapeutic management, we already said that we would use prostaglandins to reestablish blood flow. And I think that's good on that slide there, therapeutic management. Okay, nursing care of the child and family with cardiovascular disorders. Parental attachment can be impacted. Parents, in order to have an attachment with the child, it has to be reciprocal. I mean, the child has to be responding. If the child is not responding because they're so sick that they can't eat or respond, or they cry a lot, they cry weakly, something appears to be wrong, that causes some parents to not be able to bond with the child and create normal parental attachment. And we have to help encourage that. That's one of the things that we do as nurses. Their child development may be delayed as well because of their illness. And then one reason that we might do a Denver 2, in looking at it, a child that has a chronic illness, just to kind of see where that delayment is and how we can intervene. As far as education, the family needs to have everything they're going to need there at the home to manage, oxygen, extra oxygen, what they're going to need to know. They're going to need to know how to respond to a tet spell, or they're going to need to know how to, get in touch with the doctor or get in touch with a nurse that they can talk to right away. Parents really get concerned about kids playing and getting overexerted, and I think I've already kind of expressed that kids when they start getting tired, or but to try to allow them to have as normal a life as possible, and they need to have an opportunity for play, because that's a part of normal growth and development for every child. Child and family preparations for invasive procedures. We need to make sure that we do pre-op teaching. If they're an older child, say school age or older, we can take them to CCU, let them hear the sounds of even the EKG machine, even with a preschooler, because it kind of makes clicks and it makes noises as it, cuts on and off. And so, they need to know what that's going to sound like. Alarms, they need to know what those are going to sound like so that they're not frightened of those when they hear them. On a preschooler, you could also take a doll and show them what an ET tube looks like and how an IV goes and some things like that, so they would really know what to expect. Put some monitor leads on the doll, just kind of let them play with it and see what that's all about. And of course, you just always want to make it age appropriate based on their developmental level. Consider previous hospital experience. Consider their temperament. Is this, a difficult child? Is this an easy child? And you want to involve the parents also, and encourage them to ask questions. In addition, it's always good to be able to, because you don't exactly know what people's fears and concerns are. So it's good if people ask questions. We want people to ask questions. Post-operative care and discharge plan. They will have intensive care monitoring in the ICU for cardiac surgery. Vital signs are going to be, very frequently the first 24 to 48 hours. The temperature may rise up to like 100 degrees due to inflammatory process. The doctor needs to know about this immediately if they have an elevated temp. Also, I didn't mention this, but if a kid has cardiac cath, the interventional radiologist or the cardiologist, somebody needs to know, even if they're just having a little bit of oozing, because they may want to go back in there and look, or they may want to evaluate and see if they're having any kind of a hematoma underneath that incision site. So that's real important to report also. If the child develops a fever, you want to move blankets, document the temp, get in touch with the doctor after the first 24 to 48 hours if they get a fever. The first 24 to 48 hours, it's kind of normal response to the inflammation and the surgery and that sort of thing. They want to have a lot of rest and activity. You're going to keep their legs straight, so you might have to have some kind of little immobilizer on there. Mom and daddy helping with that to keep their leg, if it's a groin, their arm, if it's if it's done through the wrist or through the brachial area. And then they need to have discharge instructions, referrals, when to follow up, and any patient teaching that's particular to medications or to care of the incision site. Acquired cardiovascular disorder, we're going to look at each one of these individually. They are bacterial endocarditis, rheumatic fever, hyperlipidemia, cardiac dysrhythmias, pulmonary artery hypertension, and cardiomyopathy. Okay, as far as bacterial endocarditis, it can be bacterial or infective or subacute bacterial endocarditis, and this is any infection of the valves and inner lining of the heart, and if there's any damage to valves, or post-operatively, or even just if the child has some major cardiac complications or defects, that makes them more prone to have a bacterial, and certainly if they've ever had any surgeries before. And causative agents are strep, staph, fungal infections, and even like candida. And this can also occur after dental work. So every child that has had any type of cardiac intervention, cardiac surgeries, have had endocarditis in the past. They need to have a pre-medication for prevention prior to like any dental procedure that they're going to have. And this is, I expect you to know this too, an infection of the valves in the inner lining of the heart. Also endocarditis, and it can have a gradual insidious type of onset. If a child has unexplained fever, anorexia, malaise, weight loss, and then they do a blood culture and something cultures out, they may have a low grade fever. And what the therapeutic management for this, if they determine this is what they're having, and there may be some other symptoms as well. Some of the other symptoms that go with this that are splinter hemorrhages, which are like black lines, hairlines underneath the fingernails. They may have what's called Osler nodes, and these are red, painful nodes of the fingers and toes. Okay, that's one kind. There's one that's not painful, painless, is Janeway lesions, which are hemorrhages to the palms and the soles. So those are two different things. And also they may have petechiae to their oral membranes or to their face. And they may also be experiencing things like congestive heart failure and cardiac dysrhythmias, or they may experience those afterwards. Rheumatic fever, it occurs after group A or B hemolytic streptococcal or strep pharyngitis. The incidence is often in late school age children or adolescents. It's pretty rare in adults. Supposedly, it's not seen very often in the United States, but it's a real big problem in the third world country. And I think it was last year there was a pretty good outbreak of it out west. So it's not totally, eradicated yet. It affects the joints, the skin, the brain, and serous surfaces, and the heart. It can cause heart valve damage, and it is a really serious and has some real serious common complications from heart valve damage following rheumatic fever. Carditis, inflammation of the heart, polyarthritis. They may have swollen joints, chorea, which are uncontrolled movements, particularly of the face. Complications or cardiac valve damage. It is referred to as cardiac heart disease, and it's really a significant. They can be reinfected. They need to repeat antibiotics for dental work and infection and for any kind of invasive procedures. Prevention is treatment of strep. Make sure that we prevent, we treat strep, tonsillitis, and pharyngitis with use of penicillin, erythromycin, and sulfa drugs. And they need to continue to have a medical follow-up for at least 5 years, both for reinfection and also to check them for any sequential damage to the heart from the disease process. And then we're going to talk about hyperlipidemia. I didn't flip my... We're going to talk about hyperlipidemia in the pediatric patient. Yes, children, younger and younger children are being seen with hyperlipidemia. Sometimes it is a familial thing. People in the family have a family history of hypercholesteremia and hyperlipidemia. So if kids, we know that's in their family, we need to treat them early with preventative diet and restrict the intake of cholesterol and fats, and also exercise. Now this almost always, unless it is something genetic, will help children to not have to go on medicine. But if they cannot get it down with diet and prescription, then they'll do cholestyramine or Cholestid or cholestyramine or Questran, which is like you've probably seen that with adults. It's a little mix that makes a little orange drink, or can be put in juice. Okay, a group of rare disorders that results in elevation of pulmonary artery pressure is pulmonary artery hypertension. Sometimes they don't know why this happens. I have heard of a little link of it to sleep apnea. Can certainly cause some backup of arterial circulation. Pulmonary artery circulation, but clinical manifestations would be dyspnea with exercise, chest pain, and syncope, and this can go from being mild to being life-threatening, and there's really not a known cure, so they treat it palliatively or treat it symptomatically with oxygen and vasodilator therapy. And of course, if the child had sleep apnea, definitely would need to be treated for the sleep apnea as well. Cardiomyopathy, decreased ability of the myocardial muscle to contract. And again, this is often, they don't know what causes it. They just know that the kid has an enlarged heart. And management is based on the same as you would for congestive heart failure with digoxin and oxygen and vasodilators and vasopressors. Management and then they'll do a correction of the structural defect if that's possible, if that's what's causing it. If they're having some type of blood flow issue, then that it would be corrected. A heart transplant is often necessary if the heart becomes so damaged with cardiomyopathy. Heart transplantation, cardiomyopathy with ventricular defects. I mean, those are very often the ones that end up with heart transplants, and it is an option for kids with worsening heart failure. Infants are the largest group of transplant recipients, and there's like a grid they put them on, and the child who needs it the most is the first one to get. They base it on a number of different factors, and there are organ donation issues because of the number of about 5,000 heart transplants a year. Infants get the most of those, but that's only 5,000 a year, and so more are needed, but then there's just that's just what is available. Rejection and infection, they are going to be on the medication for the rest of their life, and there are potential long-term problems. I mean, they could do this and still, they still would have, heart failure or failure of the transplanted heart. Kawasaki disease. This is a rare but very dangerous disease, and it's usually self-limiting, but it can cause vasculitis to the point that it results in coronary artery aneurysms. The cause is unknown. It's not spread from person to person, although it has been kind of seen as seasonal. And the kids, the management of it is clinical manifestations. I'll show you some pictures on the next page, but they'll have a strawberry tongue. They may have peeling palms, feet, rash, and swollen lymph nodes. And one of the very hallmark signs of it is that in spite of any antipyretics given, that the fever just doesn't come down. If it's irresponsive to antibiotics and antipyretics, and they have some of these other factors, they almost always, it ends up being Kawasaki disease. And they say it's pretty rare. And then again, you'll see, 3 kids in a year, that will have it. What they do is they give high doses of gamma globulin and salicylate administration, and give them within 10 days of onset. They can have pretty good outcomes. The main thing is to make sure that it's done early in the disease process. To make sure they are in the acute stage, they are very irritable, as you might imagine, with this very red tongue and broken out mouth, peeling palms, just some of the symptoms. And then in the subacute, they're at real risk for cardiac injury. And so they, in a subacute phase, which is after they've started the antibiotics and salicylates, they will check them a few times and make sure that they don't really have any real cardiac damage from coronary artery aneurysm. Here are some of the pictures, and you probably will not forget them after you see them. This is a strawberry that's in this kid's mouth, but it looks like a strawberry tongue, but I think it's actually a strawberry in the kid's mouth. And then there's a rash, various rashes. You see they're pretty severe on the kids, and then they don't really show it, but palms and feet definitely peel with this type of disease process. And then the last thing to talk about is something you've already talked about in med-surg, but just kind of talk about a little bit from from a pediatric side. It's real similar. The sequela and the treatment of shock in pediatrics is real similar to that of adults. You have early shock with apprehension, irritability, normal blood pressure, but you're starting to have a narrowing pulse pressure, thirst, pallor, and urinary output is decreasing. Unexplained mild tachycardia, decreased perfusion to the hands and the feet. So that that is in the beginning. You can have different types of shock. You can have hypovolemic, distributive shock, like anaphylactic or cardiogenic shock. You remember that treatment revolves around maintenance of ventilation, circulation, the airway, and then get the IV in, and then antibiotics, getting them warm. If they have to have blood, we give, they might even give blood that's been warmed. Positioning, making sure they're to the position of comfort, and also to be able to breathe normally. Compensated shock, we kind of talked about that, kind of the early early shock with normal or increased blood flow affects, and then decompensated, that it becomes evident. Now the cardiovascular system begins to fail, and you start seeing hypoxia, metabolic acidosis, and then dysfunction in the organs. And then it moves into irreversible or terminal shock, where there's damage to the vital organs, and the child would continue to deteriorate despite intervention. So I would expect you to know this definition anyway, but shock is a circulatory failure characterized by inadequate tissue perfusion. I don't expect you to know what the definition of shock is and what kind of symptoms would result from that. One type of shock that I didn't put on the slides here, but anaphylactic shock is such a big thing, with so many kids and adults, and for that matter, developing allergies to nuts, peanuts, and also like latex type of allergies. And so this results in a clinical syndrome where there's an interaction with an allergen to somebody who's very hypersensitive to it, and it causes, as it goes into the circulatory system, they have a very rapid reaction to that, vasoactive from the histamine release or histamine-like substance, and it causes vasodilation, bronchoconstriction, and increased capillary permeability. So penicillin allergy can have an immediate within an hour, and a lot of our kids get penicillin, and so it's really, if they have any kind of skin eruptions, rashes, or anything like that, if they have laryngeal edema or anaphylactic shock, then it's very, very serious to that. So any kids, I guess the take-home message is, like any kid that has allergies, they should get skin tested so that people know what they are allergic to, and that any allergic reaction should be treated very seriously, because it can move from a mild skin rash to anaphylaxis in a very short period of time. And once the child gets bronchioles start to constrict and they start to get the laryngoedema, then it gets very serious as far as being able to intubate the child and to be able to perform life sustaining measures to bring the child back. So that is the end of this lecture. Thank you.